Okay, thank you so much. Okay, so again, let's go a little bit for the outline of the talk today or the meeting. I was telling you about has been like constant like a century in difference, like 1817, Mr. Parkinson's was describing this condition. One century later, we had the pandemic, was in the 1918, and the second pandemic was 2019. You don't think, oh wow, this is so centuries, and now we go back to order to Mr. Parkinson's. And the England Journal of Medicine
This is a good volume.
of the Parkinson's in October last year, and the last review was back in 1998. So have been talking, and still the thing that Mr. Parkinson described in 1817 is still there, and we got to get a little more information about this. As usual, beside that article, where we like the main, we got little pics in the visit today with the Movement Disorder Journal. And before that, we just had lunch. I just want to get a little bit here. This is go like this. So you know this lady right here. And we are in the park.
There are many things that lure new residents
Volume,
here to the sun, like our beautiful beaches, our great weather, but also our top-notch medical care and support facilities.
Our next guest came
You recognize somebody there, right?
Parkinson's disease.
Who's
Now
that?
Susan Belisi.
Thank you, Susan, for all you do. She gets a good.
All movement disorders. Welcome, Susan.
Oh, thank you, and thank you for having me.
We're delighted to have you here.
You know, to do the interview. Susan, look at you. You're in the news.
So my husband has young
Susan, you're like outside. Please give an applause to Susan. Look at her.
and we lived in New York, grew, met,
So
raised a
today is going to do honor for that. We'll look as well. There's a physician that's part of our group, and as well with Susan of the classes. Of course,
around the city, and I
we don't
just
want to
couldn't
go over all the things. I think we need to do more
And
money.
also with
Susan, can you do live,
$5
right?
to $600 a month in co-pays because
You have you have the actors right here.
these therapies, and I just couldn't keep up with it. So I went home and I Googled free things for Parkinson's, and up came Parkinson Place.
Oh,
And so I called my daughter and I said, I think we're going on a trip to sunny Florida. And we went and we got off the plane.
Yes,
We
Susan,
went
welcome
and we
to
said,
San Gloria, Susan.
this is the place for us because it's free resources, everything that somebody needs for Parkinson's in one
in
location.
one place.
In one place.
What are some of those programs?
Yes, in one place. I don't want to go the whole thing here, but. So thank you, Susan, for being here. And let's continue. So this article in New England Journal of Medicine, they want to go for the biological definition of Parkinson's. So let's listen to the guys here. Actually, the director of the International Movement Disorder Society.
Welcome to the MDS Podcast, the official podcast of the International Parkinson and Movement Disorder Society. This is Michele Matarazzo, editor-in-chief of the podcast. In today's episode, we're diving into a topic that is generating a significant attention in the field of movement disorders, which is the biological definition of Parkinson's disease. We'll discuss an article titled International Parkinson and Movement Disorder Society Viewpoint on Biological Frameworks of Parkinson's Disease, Current Status and Future Direction, that was published in the October issue of Movement Disorders Journal. To discuss this pivotal paper, we're honored to welcome its last author and the president of the MDS, Dr. Victor Fung. Victor, thank you for joining us.
Thank you, Michele, and it's a pleasure to speak with you again.
So let's begin with a straightforward question, although I suspect that the answer will be a little bit more complex than the question itself. The question is, Victor, what is Parkinson's disease?
So I think that is the fundamental question that is driving this debate, of course, Michele. And I think for me, the answer to this really lies in having some historical context. As we all know, Parkinson's disease started off as the shaking palsy. So not necessarily Parkinson didn't describe it as Parkinson's disease himself. He lived in a different time when people weren't so narcissistic. And so he called it the shaking palsy, and it was clearly a syndrome. He observed these clinical features, which we all know about, motor, but he also described non-motor symptoms in half a dozen people that he never actually examined or looked after, people he observed on the street. And of course, you know, what James Parkinson described was a clinical syndrome. And it's been debated, of course, whether all of those people have the same disease. There's a suspicion that at least one of those patients that he described had a Parkinson's plus syndrome. But it was later Charcot who decided to use the term maladie de Parkinson, and that's how the name became Parkinson's disease. The next step was into understanding a little bit about the causations, Levy's discovery of Levy bodies, the eosinophilic inclusions, that in the early 1800s. And then it was really Tretyakov who really established that the essential pathology was in the substantia nigra. And so now we're beginning to form a clinico-pathological concept of Parkinson's disease. And it was actually really in the 1980s, a very influential paper by Andrew Lees and William Gibbs that really emphasized that the importance of the Levy body and how that was really essential in our, what we understand to be a so-called idiopathic Parkinson's disease. So that takes us to the 1980s. And then not long after that, a decade later, synuclein was discovered as the first monogenic cause of Parkinson's disease. And the discovery that Levy bodies were stained positive for an immunostain to synuclein then led to.
So first of all, to hear all the podcast volume again. You hear me? Okay, so again, Mr. Parkinson's described first. His name was yeah, you can hear me. I think the volume line will have thank you. And my the battery is off. Thank you. It sounds like when you are in the office and they're doing the thing outside and the month. So basically, we talk about description for Mr. Parkinson in the 1870s. Then Mr. Charcot said, no, we have to honor Mr. Parkinson's. And then later on time, they discovered the alpha-synuclein and the Lewy bodies. So basically, now we find we getting a biomarker, which is a mucosal protein in the alpha-synuclein, that when you get like in clusters or like in small packets that we call the Lewy bodies. You guys are thinking Lewy bodies only like Lewy body dementia. Lewy body is actually the pathology that we found people with Parkinson's. Back in the day, the only way to diagnose Alzheimer's or Parkinson's, where people die, we have the tissue, we get the stain, and we get the Lewy bodies. But nowadays, actually, we can do a biopsy. Nowadays, we can do that again. And now we have biomarkers. And the future of this is getting antibodies against the alpha-synuclein, because we do in the clinical practice. So let's go, that's just a little beginning. So this is nothing I want to promote. This is one of my pictures. Have a hoist, so I want the people with Parkinson's. Whenever you travel, just take a picture of the sunsets. We're going to know the picture for the month. So please, bring to our attention, go to Africa, you go to the Mediterranean. It was in Naples, so that's beautiful sunset. I love sunset. That's one of my hobbies. Sometimes in in the running day, just go to the siesta key or you go to Turkey. I like to do pictures. That's my hobby. I got my mom in there. Yes. That's good. So if you have any pictures to submit in the month, please send it our way. So let's go from this in the last you see March 15, so it's brand new. It's still one. This is the journal. There's two journals for the International Movement Disorder Society publications. One is the clinical practice, and the one is just the movement disorder. So we're talking about Parkinson's being idiopathic, but it is present a very rare case of infection. It's an amoeba. It's a parasite, and actually you can see the new ones. But this lady had Parkinson's because had an infection for a parasite. It was very dramatic, and it actually had been described only 2 cases. So we'll go back to the okay. So let me see the full article will not be there, but let me see the works. And you can work with them. Right here. And you can show the videos of ways. So we go back and forth to the other. And this is the for our membership. We get this. When you try it again, you know what you find there. You don't copy my password. Actually, the place where the Movement Disorder Society the headquarters is in Milwaukee. You might think we were one in the NACA College of Wisconsin. So by then, probably from Colombia, we don't have snow. We don't have seasons. So it was 4 in the afternoon. I was a new resident in the NACA College of Wisconsin in Prairie Hospital. And I started seeing something very nice coming from the sky, like Houghton. I thought, oh, beautiful. Houghton. What is that dark? I get a little depressed. I love the sunshine. That's why here, right? And then after the snow coming from that, I went to drive. We don't use too much automatic cars in our country. So I got to one of these cars and went to the snow. I don't deal with the snow well. And I just did a little, I hit a car in front of me. A lady was very upset with me, but that was my short love with the snow. And after that, when I saw the snow, I said, no. So, it's going to where I'm going to back. So let's go to just there was a case with this lady. Maybe this is going to work. So this lady, hopefully the video is going to run. Okay, you have the case right there. This is the Ankylosing evolution encephalitis presenting with rapid developing Parkinson's disease or Parkinsonism. So secondary Parkinson's disease is another thing. Most of the time we call idiopathic, like 85%, but we call to our attention a case like this, like multiple etiologies, like infectious, in this case, autoimmune, paraneoplastic, drug-induced. Drug-induced is very common. So people come with psychiatry problems, usually using Zyprexa, trying to fix some schizophrenia, or many times now we have people having depression, bipolar. They use for that something like Zyprexa, and all these medications do is blocking dopamine. So if you decrease dopamine, guess what? You get Parkinson's. So they get drug-induced. So I look at the list of the medications. I say, okay, you're taking Zyprexa. You have a thermal before this lesson now. So I say, okay, probably it's the medication. So decreasing the medication or take it away. Guess what? We can cure the Parkinson's. So it's a Parkinson's, drug-induced Parkinsonism. Now you look at this, and this is actually what to call your attention. I will tell you 1 century apart. Now we have the COVID-19. So this started in 18, 17, 19, 18 was the first pandemic, and now 2019 we have another pandemic, and guess what? COVID is producing Parkinson's. So, see in this article, and it's coming from the Institute of Health. There are several cases, and I think I have a couple of cases of people with COVID-19 induced Parkinson's disease. And some drugs for prostate cancer. I have one patient come to me after having prostate cancer. They give medication for the prostate cancer, and he developed Parkinson's. I tell you, it's not black and white. You have to go. And here it is. This is the guy. This is the amoeba. In this case, and this is the microscope. And you see this color right here, like a more purple. Is the amoeba. You find in the microscope producing the Parkinson's. This is not an amoeba. This is the red moon, right? You have that. So we have Korea, so it looks like an orange. So orange is fine here. So they're gonna try to keep you away.
Okay.
And this is the MRI of the myiasis that produces encephalitis, and produce we call like hydrocephalus. So you see here in this picture, in the center there is more water. This is supposed to be together, but you see this like more the hole there. That means there is more water in that brain. So that's not specific that they found that issue in that patient with this. Okay, so what's the thing we take from this? So we have secondary Parkinsonism, and it could be not simple, it could be a different group of conditions. Again, it's not black and white. It's not like people have idiopathy. Some people have toxin-induced, like veterans. We talked about before in our talks. That could be autoimmune. Some people having another rheumatoid conditions. Paraneoplastic, some kind of tumors. Vascular, like strokes in the basic area. Or trauma, like Muhammad Ali, right? Parkinson's, unfortunately. Being so agile is so powerful, and unfortunately, then after having the stroke, they basically have Parkinson's. And because we're so was traumatic, then was not like a dopamine, is because we killed the areas of dopamine. Unfortunately, it was not treatment for him. And we're looking now more genetics. We're talking about especially for novel chemotherapy. So call my attention with that patient with the prostate cancer, but some chemotherapy can start producing damage in the dopamine system. So there is a lot of things that we have to look, or we call secondary causes. We talk for the most part 85% idiopathic, but probably the expression I would say we are idiots. We don't know. We discover more and more secondary Parkinson's disease, and we explore more genetic. I think the Parkinson place was approached from the Parkinson Foundation to have genetic studies, and I don't know how they explain that, but this is part of the future of discovering more reason to have Parkinson. Okay. So back in the history I was telling about centuries by century, in the previous pandemic, Mr. von Economo was described the encephalitis lethargica. So the encephalitis lethargica was for this virus, and I show you that movie in the previous, how these people was like able to move. They send the tennis ball they carry here. In that movie as well, they show how people start with levodopa. So I always encourage you to see the movie or watch the movie, because people, somebody comes to me in the office today having nausea, and then taking injection carbidopa, but taking levodopa, because the levodopa is the one that prevents you to have the nausea. That's the carbidopa. The medication is the levodopa, and the second number in that carbidopa. You said 25, 100. The 25 is the levodopa, is the part of the medication to avoid the nausea. And the 100 is really the amount of medication. So we do the calculation for medication I love a lot, and I have to hear from you if you can to participate about the correct some I love them. Patient is the 91, it's some for the most part important. So the back to the chronic animal, describe how they discover they paralyze they play the dopamine level. But that's what happens or in order to do the practice that is taken, you have to start. So, it's cool. I see. Okay, so talking about infections, I'm talking about our virus, like asymptomatic virus, with the varicella zoster, very common at the children, for so, you know, the face. Varicella zoster, they go to cerebellum, this. But guess what? What about it? With mycoplasma, toxoplasmosis, basically the Victorfocus, all of these. I'm just presenting that application in you. So, talking about much of the area. They actually complete some of their same basically they found they about Vaya. Let's put some different topic here. So now there is some about events. That or the growth concept. I'll show an actually okay, so I think it's
Finger taps on the right. Big as you can, fast as you can. On the left. By stamping your right foot on the ground.
It's
On the left. And back towards.
And actually, people with Parkinson's
So what do you do to feel more comfortable? And as you're standing, what do you feel?
The contraction is still here and here, but it's better because I can breathe properly.
Big as you can, fast as you can. High as you can, fast as you can. That's it. On the left. All right. And would you be able to tap your right foot? Yeah, that's it.
At the video, we can look before and after. When I give some concern about people getting with the sense of them or Parkinson's, with DBS I showed you before and after. Look at this. You remember this guy was looking like this, and look at how he's walking. Look at the arm swing. That's very nice, beautiful. So see, we that changed our minds. But you said it's only for Parkinson's, it's only for the two Parkinson's. But look at this guy and this doing the Philippines. So you see, like Shakira said, hips no line.
They feel any involuntary movements or spasms.
More pitch. Right. Here I have another video here. This is before the
Monday, Tuesday, Wednesday,
Estonia out there.
Friday,
Yeah.
Saturday, Sunday.
Okay. And stick your tongue out. That's it. And spread your fingers.
Yes, that's what we do actually. We not meet with patients. So look after the
Where does it go? Yeah, and just once again, can you say baby hippopotamus, newly laid linoleum, lovely yellow lilies. Never mind. Big as you can, fast as you can. And on the left.
Okay, so that's the deep brain stimulation in Estonia. So we're very happy with all the dance we do in Parkinson's. Again, the reason I moved so especially because when in my second year I was in Georgetown, I saw somebody with Parkinson's with very bad tremors, and I was introduced to DBS with my technical propaganda. We see somebody with very bad tremors, they turn the DBS on, and the tremor is totally away. So that blew my mind, and I love to see, and always we have tears of happiness when we can stop the tremors like that. Okay, so for the special case and people we're talking about, we want to review the Parkinson's. This is the New England Journal of Medicine. I recommend always when you look at any information, because you can write whatever you want in internet, you have to look for the good sources. I recommend again the Montessori Society Journal, the New England Journal of Medicine a lot. You know, probably the best medicine that we have is the medicine in Boston, and New England Journal of Medicine is always one journal where we get like good evidence and we respect very highly. So this is a review that was done on October of last year. So let's say October 3rd, 2024. So let's talk about Parkinson's. Let's go to the basic again. Let's review this article together. What's happening? What is new? What are we doing? We're going to look what we can accomplish today. I don't want to watch this. You can ask me questions, but again, it's very important to get the fundamentals in Parkinson's. And what is new, what they recommend, and you probably know most of this already, but let's review it. It's a nice review of the New England Journal of Medicine. So we're looking about how bad is the Parkinson's around the world. So we're looking at the amount of cases will decrease with the time. So, and depends on the age, the older you are, the more prevalent or more incidence of Parkinson's. So remember the review back in 1998 and last year, so they making an update they found before. And again, by the time since 1817, many things that Mr. Parkinson described still is there. So again, we're talking about 2 centuries at least, we're talking about Parkinson's disease. So we usually would do our clinical diagnosis, but we have more resources now. We talked about before AI, artificial intelligence, we talked about biopsy, we talked about the biological definition of Parkinson. You hear about the president of our society, Immune Society International, talking about this. I didn't give you all the postcards that you access to in the web. You can get the full conversation. Actually, there's controversy in the end, so I'm not place everything there. So basically, for 2 centuries, we're talking about Parkinson's disease that is characterized for the following. Usually we look for the motor, but remember it's not only motor. So we're looking always about the resting tremor. We're looking about the bradykinesia, meaning brady in Latin means slow, and kinesis movement, so bradykinesia. As well, we're talking about the stood posture, the resting tremor, the rigidity. We call the co-willing. Remember the old German was the wheel, stop and go. That's the co-willing rigidity. And the postural reflex impairment. So basically, we're looking about dopamine or lack of dopamine in the substantia nigra. We call it Negro striatal system, but it's not only there. It's when the alpha-synuclein approach, then that part is when you start having the symptoms of Parkinson's, it's not the resting tremor, but that's not the only thing. Remember, initially, we talked about possible beginning from the guts. We thought it's going to enter from the guts, enter from the brain in the previous talk last month. So basically, many people start with constipation before getting any other symptoms of Parkinson's. Or many people start with lack of sense of smell. And talking together we just talked about COVID, many people start with decreased sense of smell or taste. And Parkinson's, many people with Parkinson's have decreased sense of smell. And many, or a lot of junk, or a lot of part of the taste is a smell. It's like you have a cold, definitely, usually your food didn't want to taste the same. As you just imagine that somebody going to the wine. A good people know about the wine, the smell is okay. This is what in Italy they will serve with them before even taste it, right? They know about the smell and they go to the taste, and that's very important, and that's why people with Parkinson's know how good sense of smell. They don't feel the pleasure of eating, or then they overcome with the Parkinson's, not moving the blood well, absorption is not good, and they don't get to the constipation, so they will be more floral. So that's mainly common in people with Parkinson's, suffer more from losing weight. So let's continue with review this article. So let's go for the epidemiology. So in epidemiology, we talk about incidence and prevalence. Incidence is the new cases per year for 100,000 people in that population, and the prevalence is the new and the old cases in that particular population. So you're looking about the ratio between male and female. Before we said 3-to-1, but I think this is getting a little more prevalent in females than now. We're talking 2-to-1. More common in males, but it seems to be more frequent now in females than we thought in the past. Before we thought 3-to-1, now 2-to-1. Now, talking about the age. So the older we get, the more risk to have Parkinson's. Usually we say the age of start Parkinson's, I call it the 6th floor. When you go to the 6th floor, 60, it's more or less the time when you get the Parkinson's. You get to the retirement, unfortunately, the time that you get the 6th floor. You see, we're talking about the snow. in our years. So basically, you go from 45 years, the incidence or the amount of cases is 47 to 77 for 100,000 in that population. 45. So it's not frequent. You get older, it's 60, you get 212 per 100,000. So you see the difference, right? From the age. So you are in the fourth floor for 40 years. The chance is 47 people in 100,000 in that population to get Parkinson's. They give more than 65, 212. You see the difference? Big difference. So more people you get Parkinson's. And we'll see about the race. So talking about ethnicity, you see this more common, and this has been studied, of course, in the United States, it's more whites, but there is more in white persons than in black, or they don't mention Hispanics, so they say, they said nothing about Hispanic, but they say here, 570 cases for 100,000 persons. They're looking about the more in whites, and but again, it depends on the exposure, veterans, occupation, so it's not only that. And looking about mortality, we usually say you have a control Parkinson's, usually the lifetime is the same, but you see this article is not. You see definitely Parkinson's can convey more mortality, so it's complications, falling, aspiration, and a lot of things that can complications. And I'm talking the money, about taking about how much they spend for people who have Parkinson's in the United States have been increasing from 52 billion, and this calculator is going to go to 79 billion in 2037. So you see increasing and how much is going to be the price and the public health. Okay, so let's go for the definition of Parkinson's. So I think Mr. Parkinson defined it back in 1817, but let's go a little more in details, and you know this, but let's review it. And then there's not only one Parkinson's, or we talk about the classical Parkinson's, but we have been talking about Parkinsonism. We have been talking dopamine deficiency, and it's not only one disease or one condition. We always have a tendency to define Parkinson's only tremors. Parkinson's is beyond that. Parkinson's is not only motor symptoms. We call premotor and non-motor symptoms. So let's go for the motor, which is the classic. The people understand better, but that's not the only thing that defines Parkinson's. But remember, you cannot be defined as a person just for your Parkinson's. So motor syndromes basically is what we're looking about lack of dopamine. So that's the most important part of the diagnosis of Parkinson's, the cornerstone of the biological now diagnosis of Parkinson's. Many people say, no, but I don't have the alpha-synuclein, or sometimes we get the diagnosis, and most of the time we say, very proud to say, my training, my clinical diagnosis is more important, but sometimes it's not black and white. When you come to very early age of Parkinson's, sometimes they say, sometimes we can do the DAT scan, and now we want to promote as well the alpha-synuclein biopsy. My partner Dr. Rota played with the biopsies, and we get that in the clinic as well. So we probably want to offer that soon. So the biological is like in Alzheimer's. Now we have the beta amyloid PET scan to make the diagnosis of Alzheimer's. So you have a question about Alzheimer's. We can actually say, it's like, remember back and they say, you're pregnant or not pregnant? No, I'm not pregnant. Or you look at, I have COVID, you coughing, no, you have COVID. No, I don't have a COVID, I have flu, I just have common cold. So there is a way to define, we can do now biomarkers. So the alpha-synuclein or the Lewy bodies is the thing that define Parkinson's. It's the biological. So that's the way you have it out, we can go to the biological straight, or just with this very evident, we can just treatment. Many of you say, oh, but why do I have to do dopamine challenge? If somebody is naive in dopamine, I want to define from the beginning how you react to dopamine. You go to the Parkinson's or you do the Parkinsonism. But it's not black and white. You do well with the medication, most likely Parkinson's. but you don't well with the medication most likely Parkinsonism. Because again, the biological of the alpha-synuclein is different in the neuron affecting or producing Parkinson versus is in the glia or so the alpha-synuclein is affecting the cells that support the neuron. Then the cell by itself that produces dopamine is full of dopamine. If you try to do dopamine to this guy, they don't work. That's the Parkinsonism. So that's sometimes it's a typical, or there's a question the medication not working. That's with the dopamine challenge, and they will tell you most likely you have that. But in the future, the DAT scans, MRIs, and the neuroimaging, we can tell us more in detail and more fast. Because sometimes we are looking clinically, but all this technology, you see the artificial intelligence everywhere. Even DBS is going to be more going to artificial intelligence now. So they were to figure out from the artificial intelligence, not doctors, that you're wrong. You have this different condition. So this is a multiple neurological disorder. So it's very important to look for the non-motor symptoms. Let's start a little bit here because this is very important. Before having tremor, people have problems with sleep. It's very common that people have REM sleep behavior. There's no excuse to kick or hit your partner in sleep, right? That people scream. And actually, I have some people with Parkinson's falling from the bed because that REM sleep behavior. So let's stop a little bit right there. What's that? So basically, when we sleep, there is a phase of the sleep, is the REM. It's standing for rapid eye movement. So it's like you are an observer, you're watching a movie, but in that movie, you are the present in the movie, but you are not part of the movie. You're just watching. You're watching the movie. You are not part of the movie. And people with REM sleep behavior, they actually want to participate in the movie. So basically, they start moving. Usually, with many people not having dopamine deficiency, we paralyze, we sleep, or we dream, and sometimes we remember, don't remember. Also, by the way, you are there and say, oh, well, what happened? Whether the dream was a good dream or was a nightmare. But people with Parkinson's very common have their REM sleep behavior, dreaming, acting, screaming, because they're very vivid dreams. And actually, for that, we have to be medication for that. So that can actually precede for many years the Parkinson's, or it's more prevalent in people with Lewy body dementia. In Lewy body dementia, we have a lot of people with REM sleep behavior, screaming, and so on. So a sleep problem is very prevalent in Parkinson's. Cognitive impairment. Cognition is very important. Most of the time we forget about this. At some point, you start having not only for the age, but because the dopamine or the alpha-synuclein go to the area of the brain, they call the bushes, the substantial area of the whole brain. You can have a problem with mood, or you can have a problem with cognition. So at some point, you know, your cognition is not good, we have to do a baseline. And we have now 2 nurse practitioners, so we actually have the MoCA. MoCA is not coffee with chocolate, it's Montreal Cognitive Assessment. So that's our screening we're using now for looking for cognitive impairment in Parkinson's or dementia in Parkinson's. And unfortunately, sometimes they the combination. And when patients have Parkinson's, but will have Alzheimer's. Fortunately, that can happen as well. So it's very important. You notice you have an issue with cognition and start being physically and mentally active, and at some point, remind me, you have to do cognition testing. So that's very important. Another thing is very important is the affect. I see somebody's probably crying too much. We call the limping spells that can happen for pseudo bulbar affect. There's a medication for that. Then we have about the autonomic dysfunction. Autonomic dysfunction can be happening just in the beginning in another condition with dopamine deficiency that we call MSAs or autonomic dysfunction. Or is the typical Parkinson's in the end, we can have autonomic dysfunction. So you say, oh, why are you feeling dizzy? All of a sudden I take carbiopathy and I'm feeling more dizzy. Or for some reason the blood pressure doesn't go only down, but it go up. So I'm not sweating, or I'm sweating too much, so I have more salivation. All of these signs of autonomic dysfunction. Or the blood pressure can go up or down. Very common is blood pressure going only down. So the Parkinson's plus orthostatic hypotension. That can happen. But it could be the opposite. I always ask them, you follow your blood pressure where you lie down, sitting and standing. But not only the blood pressure goes down, if that's the case, there's medication for that. But some people go up and down. It's like you're Orlando, you're roller coaster. Blood pressure up, blood pressure down, and then you get dizzy, right? So you can get dizzy not only because the blood pressure goes down, or because these variations in the blood pressure that can happen in autonomic deposit device. Sensory symptoms. So we always say, oh no, this Parkinson's motor. No, sensory symptoms can happen in Parkinson's. It's very common to have some sensory symptoms, and the special sense, not sensory, but sensorial, to taste. Let's talk about as well another. We talk about like the sense of the smell, pain. It's important parties or two different sources of pain. We talk about as well behavioral issues. So changing behavior or the recognition. We talk about as well, should we not as characteristic of Alzheimer's like sundown, but behavior changes could be together with cognition. We talk already about the REM sleep behavior, but not only that, another sleep disorder, not only rest leg syndrome. So let me stop right now about this because people confuse rest leg syndrome with periodic sleep disorder sleep. Some people just sleeping, they're moving the legs, and they're not be aware. It's just the partner, they tell me that they're moving the legs a lot. That is called periodic sleep disorder of the sleep, which is a sleep phenomenon. People are asleep, they're not aware of that. Versus renal leg syndrome. Renal leg syndrome is very common to be in people with Parkinson's, with body dementia, and that's the sensation. You lie down, you feel like ounce or like Coca-Cola in your veins, something very annoying. I just need a wish to move around, and that helps you. So you see, people need to work. And guess what? The medications we're used to release that is dopamine agonists, like propirenol, Mirapex. And some people have renal leg syndrome just with iron deficiency. So it's very common in people with anemia, with iron deficiency. So if somebody has renal leg syndrome, I have to look for the iron. And makes sense in Parkinson's. In Parkinson's, remember the substance Niagara. Niagara because have iron. So people with Parkinson's have some abnormal metabolism of the iron. And people with Parkinson's as well have more risk to have melanomas because iron black, right? So more pigmentation. So that's why I always recommend you to have an evaluation part and dermatologist once a year. So remember, there is a lot of symptoms. There is not only motor Parkinson's, it's not only tremors. So we have to remember Parkinson's is beyond tremors. It's just a sleep, it's cognition, it's the mood. It's about nutrition and exercise, right? So what's the clinical diagnosis of clinical criteria for Parkinson's disease? So that we do a lot of research, we look for the motor. And so we looking as well, I want to give you a very nice picture for this. So we have the clinical, but as well we have the DAT scan that they expect. So we have an spatial tracer. Now we use nuclear medicine for tracer for biological to make the diagnosis for many things. For example, you're thinking about prostate cancer, you have Alzheimer's, you have Parkinson's. So that's the biological part. Or we can use the alpha-synuclein. We can do it, you have your appendix taken out, or we see people doing some things from the skin. We can look for alpha-synuclein. You have family members with that, we can make the diagnosis sooner than later. The fact you have alpha-synuclein, that means you have the diagnosis Parkinson's right away, not necessarily, so you have just dopamine deficiency. And it's possibly one of the different things, but it's important to know sooner than later. That's why we now promoting in our memory clinic. You have some issue with cognition and it's nothing else. And it's looking you MRI. You MRI is small and we take people to Alzheimer's. We testing people right away and we have two medications for that. We have the Leqembi and we have as well the Kisunla. Hopefully in the future we have the same thing for Parkinson's. There is a lot of research and hopefully we'll get, but there are antibodies about amisfold protein, which is the beta amyloid. Hopefully we have antibodies against the alpha-synuclein in the future. There is research going on there. So hopefully, unfortunately, this is a neurodegenerative disease, and to get research to this will take years. But that'll be some articles in the New England Journal of Medicine. So again, whenever you have a question or you have to investigate something, go to the proper resource. Go to different things And that's why you come to me and ask me about supplementation or something about internet and this, internet and that. Mr. Google or Dr. Google, this is not good. So go to the journal of medicine, go to the Women's Society, go to the medical library of medicine for any question. You can be good about all they have vitamins and it's good. No, you can have, sorry. I don't have evidence for good or for bad. You want to spend your money that I recommend you spend your money in fruits, vegetables, and fruit. Get a good bicycle, and that way you need to do better for you instead of get this. And you get all these nutrients to have a good nutrition. So this is the key points to make the diagnosis of Parkinson's. You let me know where we are in time. I don't want to write this because this is a very important topic. It could be like a Netflix. We can do number one to be continued. The revenge. So we can do that. So let's continue with this, and you let me know. We have like 10 minutes left, but I have more time for you guys. It's up to you. You want to fall asleep? I think if somebody falls asleep, I stop right there. But again, I think this is the basic in this, and this is very nice to me. So what are the key points in this? So you can get it again. You can take a picture here. You can get an access in using this recorder. So Parkinson's disease. Remember the definition. This is a progressive disorder. Or later in life, but sometimes it can happen in people younger because John onset of Parkinson's. When it's younger, less than 40, I have people like, I have one patient with less than 18 years old. So we have alpha-synuclein. He doesn't want to go to the treatment right now. I insisted to him to try a meal inhibitor. But exercise, and doing exercise, so far people okay. So in people with young age, a little more genetic. So I will talk about that. So remember, it's a progressive genetic disease. The only thing that they slow down the progression is exercise. And we usually use MLB inhibitors. I'm very convinced in some methodology that modify the progression. Many people forget when trying something like Acelec or Rexagilin or Selegin. They say, no, doctor, it's not working. I don't see the tremor changing. When I do my score in the Parkinson's, I see the difference in 6 weeks. I all ask 6 weeks, and that works. 6 weeks, they increase that number in the unified Parkinson's disease by 4 points. So remember, we'll be continued no matter what. If we discover the cure, we will have a cure. And at Georgetown, we have Dr. Paganda was looking for the cure, and that was back in, has been like 6 years with Tasigna. Tasigna is a medication for lymphoma, and unfortunately, in the beginning, we have a lot of hope, but still we don't have the cure, and there's still a lot of things trying to fight Parkinson's. They did a lot of symposiums, and there's Dr. Michael Oken in Gainesville. He's amazing. He's a very good. We talk about how to stop Parkinson's. Okay, so again, this is a condition that is because we have the alpha-synuclein, that where this group is called the Lewy bodies, and that's the most important element that can produce Parkinson's in the central nervous system, the substantial area, or can affect the peripheral nervous system. So that's why people have autonomic dysfunction. So that's to be in both sides. Or if it's of the smell, or go to the gut, then you have constipation. You have some small neurons in the gut that will remove, and with alpha-synuclein, that is why you have constipation. Remember as well, you have disorder of the mood, the sleep, sensation, cognition. We talk about the autonomic dysfunction. So many of those symptoms precede Parkinson's motor symptoms for years before getting Parkinson's. So I said, yes, decrease in the smell, yes, I do, but it's for years. It's normal for me. No, it's not normal for you. That's the beginning. That's the beginning. How? That's the way the alpha-synuclein enters to your. We talk if the brain is the gut. You start constipation first, so you have like I said before, but the progression from the gut after. So we're looking about different reasons. For the most part, we talk idiopathic, are looking more for the genetic component. So the exposure to toxins, we talked about last time about this. So we're talking about even trauma. We look again, the only thing that decreases the risk is exercise. And we have been talking about many times decreasing the risk Colombian coffee, right? And nicotine, but remember nicotine, we don't promote smoking, but nicotine and coffee seems to be some that can decrease your risk to have Parkinson's. The reason for that is probably the nicotine and caffeine promote the good flora in your gut. So you have a good protection there, you avoid the alpha-synuclein implemented to your gut, what we call that primacy. So remember in the beginning of this talk, we talked about the biological definition of this guy, we're talking about that. So that we're looking at. Besides getting to this, we're getting more and more with technology. So in some Tesla, when I'm talking about car, we're talking the MRIs, right? Tesla 10. We're talking the MRIs, how potent is the MRI? We talk Tesla 1, Tesla 2, Tesla 3, what we have here. Tesla 10, with Tesla 10, actually, we can look at the substantial area and make the diagnosis of Parkinson's disease. So, but looking for the MRI and the DAT scan with certificate, for example, if the brainstem, the function decrease, we can look for one of the MSAs. If the cerebellum is smaller, we can find the MSA type C. If the midbrain is small, we call the progressive supranuclear palsy. Thank you for that. Very nice. Before we have only the autopsy for looking the people die looking for the alpha-synuclein, but now we have better ways to do it. Okay, so depends of the areas of the brain or brainstem is affected. For example, if the alpha-synuclein go to the dorsal nucleus of the vagus, people have the constipation. You go to the locus coeruleus, you go to the substantia nigra where you get the tremors. If the alpha-synuclein approach from the first and invade your brain, big cognition problems, then you get revitalization. So depends where we get it. So looking about pigmentation, iron, that's substantia nigra. So So what is producing Parkinson's? We're going to finish here. I want to give you a couple more videos. I want to get there to be continued. We can give some picks for the next. But let's go for the ideology. Again, I like to review this in detail with you because that's the fundamental of Parkinson's. And actually is going to see what's now, what's in the past, and what's in the future. Or what is producing this. So multiple ideologies for Parkinson's. Sometimes we say we don't know. We call it idiopathic. We just talked about in the beginning about infection. We talked in the past about toxins. We talk about people in the military with being exposed to toxins, even the air, the pollen, the pesticides in Florida, so paraquat. So we talk about 20% of people with Parkinson's that have monogenic, they some genetic. Some they become autosomic dominant. That means that 50% in that family can have Parkinson's disease. Some could be as well recessive. So in the autosomal dominant business, we're talking especially the LRRQ2. That is approximately 1 to 2% of the etiology Parkinson familial cases. We talk the GBI1, and especially in the Akhenazi Jews, it's very common, this type of Parkinson. In our part, in North Africa as well, we have the North genes, the DPSD5. And in the recessive business, the Parkinson, we have the PK1, the P1, and DG1. This is the most common ones in people with young onset of Parkinson. So I wanted this patient with 18 years old to have that test. And sometimes I think this particular case was negative. Okay, so I want to stop here and I want to go to the, give me 1 second. I want to, you turn the light 1 second. I want to go. I want to honor another person in our group here. I hope he's here. So let me go to my glasses, right? And the rest to be continued, but let me go back to here 1 second. Guess I'm bye, but not yet. Rosanna, I always say when you come to the office, listen, I have the title. So let's take a look. Now you want to call it? Let me finish another part of our group right here.
I think I know what I'm doing.
No, you there, you want everybody here. Hi, music now, they wake up and it's very long song. Yeah. And nice, that's super. What you have to do the left from salsa for that. Thank you very much for participating. Right? We did like the Travolta. So any questions while we're talking?
Here we go, look at that. Here we go.
I'm going to give you again, I left the software was saying, oh, that was less snow, less age.
With the brain simulation, is that temporary or how long is that last?
So the question for the people on Zoom is that if the DBS is something temporal or how long it lasts. So since my fellowship we're doing, and they usually years and years, it's something is there, it's implanted permanent and it's studied for more than 20 years, it's still working. So it's an implantation, it's like pacemaker, it's like you ask me how much the pacemaker or the heart going to use. Work is something implanted, it's working, it's there, it's amazing. I will show you, she asked me how big is the DBS. So the technology is getting better and better. So basically it's two parts of the DBS. One is the electrode, and now the pacemaker is getting smaller and smaller, like that. So now, with the artificial intelligence, we try to get two electrodes to actually sense the activity in the brain. That's the last advanced in electronics. So actually, they can sense what the activity is going and actually kind of accommodate and do the accommodation like you have in the car. Back in the day, you have to use the shift. Now you do automatic. So the DBS went more by itself, and now that's from this. The patrons I have no need to. We do the DBS by myself. So I'm very happy with that. And again, I see the competition is not as good because you're not using all the electrodes to contact, but I think it's going. We're very excited. And I see in this publication that usually, oh, look at that. Thank you. So you give on TV. You know what she's in TV. She's so great. So this is, to answer your question, this is the actual thing. So this is the part of the initial was like this, now getting smaller. So this is the part they're going to in your chest. You want to touch it, it's okay. No electricity. Any other question? Yes, sir.
Cancer General is starting the commercial with hearing Parkinson's surgery.
Okay.
This?
Okay, so this question is if there is a cure of Parkinson's with surgery. So I think we have been reviewing in the past. Really, we don't have a cure. We can do this high frequency ultrasound. In the past, Michael J. Fox had a palliectomy, so they take away part of the brain. But really, it's something to decrease, but it's really not cure. It's just taking or doing ablation, taking part of your brain out. So there is another technique besides DBS, is high frequency ultrasound, we talked about before. So first of all, you want to get rid of your very nice hair. You have to take all the hair out and then go back. They place a frame and then place you in the MRI. So the neurosurgeon with the MRI, he knows the coordinates to send you high frequency ultrasound, and then he produces an ablation. I always say an ablation is really work. So you said, it is the target, you got the target, fine, you get it right, good. You target like Ukraine or Russia, fighting. So you get the initial when you have to do it, the ablation, fine. But you're off, you kill severely. Basically, you can have like a stroke. Definitely, you can have like your speech. The good hand is it's a good fight. But again, we don't have here this technique, but it's in Tampa, Boca Raton, Celebration. And they have every strength, but in the last talk, we talked about that, and we said in Denmark, they did a study, there were some issues with people having some speech and gave problems with that. But again, if there's a contraindication because surgery or because cognition and it's intractable, it's an option. I don't want to jump in that, but it's a good option. Again, we are not the ones that have too many experience. I only have 2 for my patients. Patients that they honor to have only have 2 people with hyperaggressive person.
That's the ones that came and talked to us last year.
Sorry, say again.
There was a man and a woman. They were both,
Okay. Okay, so he's asking there was somebody come last year with a man and woman. I don't know if the same that I'm thinking, you correct me. But there's another thing about the glove. So there is in California, there's a doctor in Stanford, they're doing, it's not invasive, actually it's a glove, they do electricity in your hand. So you do like 20 minutes of stimulation that produces dopamine. And actually take it away and they do very well with that. It's not invasive, but it's still there. We don't have that available, but hopefully soon, but it's not invasive. But there is a lot of things. So you tell me in the specific, there is a lot of things going there. We don't have the cure yet. We're working in something like Parkinson's with infusions, something with infusions. It's something coming. How long? We don't know. I know Alzheimer's more prevalent than Parkinson's, but we know there hopefully soon. The only thing I will go more for exercise, and hopefully we can get to the Parkinson's. Alpha-synuclein so far in the target.